My name is Katie Arnold, and my mission, should I choose to accept it, is to talk about internal NHSN data validation. And I'm directing this largely at infection preventionists and quality folks who deal with the NHSN data at a facility level and need good quality data for improved surveillance and prevention. My objectives here are to describe the attributes of high-quality HAI surveillance, how internal validation can help you achieve it, and why it matters, to consider some elements of internal data validation, and to recommend ways that facilities can validate their own CLABSI and SSI data. So one definition of HAI surveillance is the ongoing systematic collection, analysis, interpretation, and communication of data that is essential to planning and implementing prevention. And I've underlined prevention because I think so often that we focus hard, and people pressures from outside facilities are focusing us so hard on the collection part that we don't get a chance to get around to thinking about the sharing and prevention aspect. But all of these are parts of surveillance, and all of them are important, and we need to maintain all parts of the surveillance loop. Quality surveillance for HAI-associated infections requires several attributes, and one of the ones that I wanted to point out is consistency and now completeness. In the era before HAI data were used for public reporting and for payment schemes, surveillance at a facility level had to be consistent and it had to be relatively complete. But because the data were primarily used by the facility itself for following trends over time and targeting prevention efforts and monitoring the situation internally, if you maintained the same level of surveillance, you could achieve the goals of longitudinal information. However, the new paradigm with public reporting and payment schemes is that really surveillance has to be done in a comparable way between all facilities, and that leads to the need for complete surveillance being the standard for all facilities. If this weren't the case, then the harder working facilities could suffer because they would achieve better case ascertainment, and the public and external validators expect that facilities are going to conduct surveillance in a complete way. So we'll be judged by this standard of completeness. So the first question that I want to pose about internal validation is, how can your facility achieve completeness of surveillance data? And a proposed solution would be to make sure that you, as the IP, review a minimum of clinical data on all candidate HAI events. And I don't mean a complete review of everything under the sun, but really to review all of the candidate events to a point where you can rule out the HAI, or that it will lead you to a path that concludes that it might be an HAI. So taking the example of CLABSIs, it's important that facilities would be able to recognize and review every positive blood culture, at least in locations where CLABSI surveillance is being conducted. And then the second step in the process might be to review that case for the presence of a central line. If you can't identify the first step here of identifying all the positive blood cultures, it'd be very difficult to assure that you had complete surveillance for CLABSIs. For SSIs, for example, you would have a need to identify and review all post-op patients, both during their initial surgical procedure admission and also for hospital readmissions, to identify those complex infections that are required for CMS reporting. And we know that since many SSIs are not identifiable necessarily by microbiology laboratory criteria alone, many SSIs occur without culture documentation. or maybe culture negative on antibiotics, that it's really important to do rounds on the wards to identify infections that may not be associated with a positive wound culture. And there's more that is needed in the way of post-discharge surveillance to have complete ascertainment of SSIs as well. So one point that I want to make is that with the increasing pressure on collection of data, more required reporting, the data that must be accurate, the data that must be complete, and money being on the line, is that we need to make sure that infection preventionists are supported and that they're not trying to do everything alone. IPs have been busy as long as they've been in business, and the job of collection is becoming bigger and more complex. So we need to build into the job of infection prevention a concept of team management. And I think HAI validation actually provides a context where infection preventionists can build teams to support their work of surveillance and validation. Validation, internal validation that you all conduct, can provide you with insights into where the systematic weaknesses might exist in your own facility and what you all might need to try to correct them, what sort of support and additional resources you might need to gain a better outcome on those parts of surveillance. And yes, validation will also give you the assurance that your surveillance data are of high quality, that they're complete, accurate, and timely, and the ability to engage a team. So I've tried to illustrate that surveillance loop showing that collection of data and validation of data are really ideally integrated, and that validation ought to be part of the concept of collecting data to make sure that the data are of high quality as they go into the loop. So the second attribute really that I'm discussing here is the need for coordination as we're doing surveillance and validation. Coordination of support for infection preventionists and their work. HAI surveillance and validation really needs to be a shared responsibility that is at the facility level. It needs to be shared across hospital units, services, and disciplines. And this will become increasingly important as the requirements by external bodies to do more and more surveillance and do more and more reporting continue to increase. So here's a question: how can an infection preventionist achieve protected time for prevention activities, which are such an important piece of the surveillance loop? Some ideas that people have suggested to me are to delegate certain tasks, perhaps denominator collection or data entry, to folks that could be made available to the IP. It may be if you're doing enough reporting, particularly widespread reporting or electronic uploads of data, that you may need support from your information technology and data systems folks to help you achieve good electronic data uploads. And new linkages over time as electronic medical record systems become more sophisticated may allow us to tap into pharmacy systems or antimicrobial starts and actually improve surveillance even further than it might be possible nowadays. But I'm hoping that people are thinking broadly about how can other people at the facility engage with IPs to try to support the work that is asked of you. So here is that same table again, looking at CLABSIs and a recommended step 1, make sure that we're reporting every positive blood culture or reviewing every positive blood culture. Who was a natural partner for that? Well, it would be the microlab laboratory information system. And I would submit to you that your microlab should be able to generate for you a line list of positive blood cultures for any surveillance location that you need to review, for a time period of surveillance that you would like to look at, so that you can double check and make sure you've seen all of those blood cultures and reviewed them, so that you know that you have had a chance to entertain the possibility of an HAI for all of those. I know that this has been something that has been a challenge for a lot of facilities, as CMS has requested line lists of laboratory information. Sometimes they've added additional things that maybe make it even harder, like the requirement for central lines. These are not things that have been built into hospital systems as a natural thing up until now. But if you wanted to be able to review central line status, perhaps you, as an IP, could consider approaching your location-specific denominator collectors and ask them to keep track of where the central lines are that they've been collecting. Or perhaps work with nursing administrators to find a place in the medical record where on a daily basis there is documentation of the presence or absence of a central line, if that's not already in your medical record system. Because working on a systems level to improve these sorts of infrastructures can make your job simpler in the long run. So for SSIs, obviously you all probably already have great relationships with the surgery staff, the OR staff, the ward staff for surgical units. And hopefully you've built relationships with bed control and your admissions, discharges, and transfer system so that you know about hospital readmissions for patients who have had surgical procedures. For reviewing wound cultures, you could build relationships with the microlab, surgical ward staff, and OR staff. But in the future, as you continue to grow your program, perhaps you will want to bridge some relationships with pharmacy folks, medical records looking at prolonged length of stay, or even ICD-9 codes looking at hospital discharge codes that could suggest the presence of a surgical site infection. And these things maybe sound like extreme ideas or pipe dreams at this point, but over time they may come to be more and more possible as we move into an electronic reporting era. I think one support system that's really necessary for IPs is administrators who need to make sure that the IP has a final call on deciding what is an HAI and what isn't according to NHSN definitions, and that the use of adjudication panels that look at the clinical integrity of calling something an HAI should really be discouraged, and will be discouraged as external validation comes into place, because external validators will expect facilities to be using NHSN criteria and methods. So the third attribute that I want to emphasize is confidence. Confidence is really important for your internal validation, and you all are here today being updated and learning all of the challenging new information about how to stay current on NHSN definitions. Hopefully this will all become second nature to us soon, and it will be easier in the long run. Facilities will be held accountable for using these NHSN methods and definitions, and the team that you work with will need to know the NHSN surveillance definitions for the parts of surveillance that they work on. So if they're a denominator collector, they need to know how to count central line days. They need to apply the definitions with confidence the same way every time, and if they don't know, they need to ask questions, and we need to encourage everyone to seek assistance when there's ambiguity. Internal validation can help with all three of these attributes of good quality surveillance, looking at completeness by double checking and investigating all the candidate events, on coordination of the facility systems that can support infection preventionists, and in the confidence in your data so that you can direct your precious prevention time on the right priorities because you believe the data that you are gathering. So why validate? Validation is important to you because these are your data. Good data will help you derive meaningful, actionable information for your facility. an ability to hold up under external scrutiny, like a CMS external validation, and incomplete or inaccurate surveillance data could affect your payment or reputation. And also, many facilities are a little bit surprised at what they find when they take a look. So this slide shows you the results of an external validation that was done recently in the state of California, where facilities are required to map locations house-wide. And I think a lot of states have already mapped their ICU locations pretty universally. But in California, they looked at the location mapping, which is really important for risk adjustment of device-associated infections. And they found that 13% of locations were mismapped, and that about half of the facilities had at least one location that was mismapped. I think this was something that was surprising to California and to the facilities. Here are some denominator errors that have been found by NHSN validation. Central line counting problems. When denominator counters have been surveyed, sometimes it's been discovered that they don't know or follow the correct definitions and methods. Electronic uploads of denominator data can miscount the information, and there is a requirement in the NHSN manual that requires electronically uploaded denominators to be correlated within 5% of manually counted denominators. For surgical procedures, we've had states report that they have identified incomplete denominators for surgical procedures based on the limitations of the sources used to report procedure denominators. So if they're using the OR schedule, it may be the fact that the add-on procedures don't make it to the OR schedule. We've had a state that told us they had a large deficit in procedures that was caused by omitting an ICD-9 procedure from an electronic procedure upload. Validation can help you discover those sorts of flaws. Numerator errors can also occur, and I think the most obvious one that could be discovered by internal validation is omissions. Many states that have done data validation have discovered omissions, blood cultures that were sometimes just missed. And even though we all think that this wouldn't happen in our facilities, in almost every state there has always been one or a few facilities that have had overlooked blood cultures. Some of the other problems with numerators may be difficult to figure out with internal validation, but they can be identified with external validation. And these may be things like misconceptions. So we had one state report to us that their hospitals did MRSA active surveillance testing, and that they thought because a patient was identified with MRSA colonization on active surveillance testing, that MRSA that was later found in blood would not be considered an HAI because it was already POA. That was a misconception. Primary versus secondary bloodstream infections are commonly a challenge. We've had states tell us that a lot of facilities will misclassify Candida that is found in both sputum and blood as Candida pneumonia, when there actually are limited criteria under which Candida would be called a cause of NHSN pneumonia. And that would be the new pneumonia 3 category, where the patient is immune compromised. So those are common errors that we know about and that can be identified on external validation. And if you are aware of them, you can anticipate them and prevent them during internal validation too. These are suggestions for internal data validation, and these are informal recommendations, and they're ideas and thoughts, and we welcome your thoughts about whether we're hitting the mark on these or overreaching or not going far enough. But some thoughts that we've had are that annually facilities should consider drafting surveillance and validation plans for the year, figuring out where you're going to be doing your surveillance, and integrating validation plans into that. Recruiting partners and updating staff training is very important to make sure everybody's aware of updates and changes to definitions, and that people know the definitions and are able to execute their tasks correctly. It's important to review the annual survey for facility descriptors and location mapping, make sure that those risk adjustment criteria are correct, so that you're able to compare against the appropriate benchmark data. On a monthly basis, you'll be uploading denominators for CLABSIs and for SSIs, perhaps for other things. So this is a good opportunity after you've uploaded your denominators to run analysis in NHSN and do checks, analysis checks for missing data, inconsistencies over time. Perhaps the numbers have doubled since the last time you looked, and that suggests there's a problem. Maybe you have duplicate data. So running your analysis checks is a really good thing to do on a monthly basis. And then to communicate with partners when you find issues and make sure that the processes leading to good data are improved and continuing to do well over time. Daily internal validation activities could include spot checks for processes. So denominator tracking, central line days might be something you want to spot check. Just stop by a ward and see what did they come up with and what does it look like to you. Do you think they're counting correctly? See how that ward is doing or that ICU is doing on denominator tracking. Looking at surgical procedure documentation. And then your active numerator collection is occurring on a day-to-day basis. When you walk the walk, go to the micro lab, review the positive cultures, go to the surgical wards, review patients and wounds and wound cultures, and also to the ICUs to see where those problems might be. So to drill down on the annual check, we know that there are error-prone data in NHSN that you could look at during your annual check, including the medical school affiliation. Make sure you know the NHSN definition of major medical school affiliation versus the lesser levels of that. Looking at the number of beds in the units that are being mapped, ICUs and specialty care areas. Looking at location mapping. And just bear in mind that as CMS adds a requirement for lab ID event in facilities, that all of us are going to have to move toward house-wide location mapping, not just ICU location mapping. Are your reporters up to date on the protocol standards? So especially for smaller facilities that maybe don't have a team of infection preventionists to collaborate with, it's really important to gather a group, perhaps your APIC chapter locally, to talk about what are the updates to NHSN. Make sure that you all understand the changes, perhaps organize a webinar or training update, and work through case studies from the American Journal of Infection Control, or perhaps share some problematic cases that you've had adjudicated with folks here at NHSN and that maybe came out differently from what you would have anticipated. You can share those anonymously with other facilities so that everybody's doing it well. For manual CLABSI denominators, it's important that the protocol is being followed. It asks that if you're doing manual counting, that it be done at the same time each day. And you need to be confident in your data, confident that your staff are counting correctly. So quiz them from time to time. Ask them, what do you do when somebody forgot to fill in the information yesterday? Do a spot check on the location. Figure out what happens when you go on vacation. Do you ask someone else to cover for you? And do they know the definitions? Take a look at the logs that they're completing and figure out what % of days the denominator data are not collected or that there are implausible data entered in there. And then involve and review the results with your staff, because if they're doing a good job, this is always a source of pride, and it emphasizes the fact that this job matters to you, the quality of the data matters, and they'll take pride and continue to do a good job for you. The annual check of electronic CLABSI denominators, I think it's important to know that the electronic denominators are commonly inflated unless they are validated. So the protocol says we count 1 central line day per patient. If you have a very sick patient in the unit, they may have multiple lines, and an electronic count for that patient might be 3 central line days, which is not per protocol. So before you begin using electronic CLABSI denominator uploads, you may need to work with information technology and tweak the way that the electronic uploads are done. The counts need to match within 5% for 3 months to comply with the NHSN protocol, comply with, or to correspond within 5% of hand counts, manual counts. And if you're a current user of electronic uploads, I would still encourage you to do spot checks from time to time, especially if you're doing this in a widespread manner. If you had some sort of big change to your electronic information system, how long would it take for you to figure out that your denominator data house-wide have gone astray? I think if you're doing periodic spot checks, you may be able to catch it early and prevent a whole lot of grief in the long run. For SSI denominators, whether the data are manual or imported, you need to know, are the denominators complete? Missing denominator information can make you look bad. It'll make your SSI SIR look higher than it otherwise would. So look at the source data that you're using. Consider the quality of the information and the completeness of the information that's coming from that source of information. And if you have a different source that might be more complete, or overlapping sources that together would give you better, more complete information, figure out if you can do a better job of capturing complete denominator data for SSIs. For procedures, especially if you do a lot of SSI reporting, if you're from a state like California, where I understand you do a lot of SSI reporting, it's probably really prudent to work toward electronic SSI denominator uploads because it's very difficult to do any of this manually in such a large way. But work with the OR staff and the IT staff to make this work, to make it high quality, and check it while you're going through the process of tweaking the information sources to make sure it works well. In analysis, you can also check your SSI denominator data quality. You can look at variables that you care about, perhaps which surgeons have high rates of SSIs. You can look at emergency procedures and some of the risk stratification variables, other risk stratification variables like the ASA score, wound class, or procedure duration. And then there are revised variables now that are used for NHSN risk adjustment that are published in the paper illustrated here. And then you might want to look at the variables that are shared with CMS. All of these are available to you if you learn to use NHSN analysis to do periodic data quality evaluations. So these are examples of some of the canned data analyses that are available in NHSN. They are canned programs, sort of generic programs, but they're also modifiable so that if you find something that needs to be tweaked for your uses, you can modify them in NHSN. Here's one that looks at procedure duration and ASA score for CABG surgeries, CBGBs and CBGCs. And here's a little recipe for how to get there in NHSN data analysis. And you can do it according to the canned program, or you can tweak it. and try to look at, which surgeons are involved or other factors you might wish to look at. Here's an example of this program that was run looking at procedure duration. And as you can see, all of these CABG surgery procedures are less than 3 hours long, suggesting that incorrect duration of the procedure was probably a problem here. So doing analysis can help you look at data quality. Here's one that shows you that many of the patients who underwent CABG surgery had an ASA score of 5, which means the patient was moribund, and probably those patients should not be getting large numbers of CABG surgeries under those circumstances. So that's likely to be a problem as well. So you may want to look at the ASA score, the duration of surgery, look at some of those variables that you could tweak the data quality. Troubleshooting in NHSN may involve considering the sources of the data that have led to problems and try to figure out the source of the problem and how to fix it. If you perform data checks monthly, that's very helpful, and especially it would be advisable to do this if you've had changes to your electronic medical record system or your OR tracking system that might lead to glitches in the surveillance data. Make sure you've built this team so that you can discuss issues with the OR staff, the IT staff, the data manager, and figure out, how to fix it. Has code omitted the procedures? Has an IT glitch changed the data? Have default values been used in the absence of available electronically captured variables? All of these things might have a different fix, but if you know where the problems are, you can address the quality problems in your data. Looking at numerators for CLABSIs, we know from state validation efforts that there have been more problems with underreporting CLABSIs than with overreporting CLABSIs. So one way to make sure that your facility hasn't just missed CLABSIs is to double check the positive blood cultures that have occurred in your facility, at least as documented by your microlab LIS. So during surveillance, stop when you can rule out the HAI, but up until that point, make sure you have been aware of the positive blood cultures. Validation of case ascertainment should include periodically reviewing the list of candidate CLABSI cases. So even though CMS asked you to cough up a list of positive blood cultures, I would suggest that for internal validation, you might want your microlab to cough up a list of positive blood cultures for you on a periodic basis, at least annually, so that you can make sure that you have reviewed all of those cases up to a point. New this fall in NHSN analysis, we have a series of quick reference guides. Maggie may have told you about these already. If I'm not sure, maybe it'll be tomorrow. Okay, so you know about these already. Wonderful. One of the things we encourage facilities to do is to look at their data longitudinally over time, because a red flag of data for data quality is if something changed over time in an abrupt manner that can't be explained by real disease. So reviewing longitudinal trends with that one data check can help you assess aberrations over time. You could look at numerators by location and overall, denominators by location and overall for your facility, rates of infections by location and overall, and then the benchmarked rates, the SIR, by location and overall. So that was a lot to suggest. I know that people already have their hands very full, but I hope you will start to see validation of the data as integral to the surveillance that you're doing, and take great pride in the high quality that you are putting into your data by validating and doing good surveillance. because then, at that point, you can use your valid data. Consider the weaknesses that have been identified by validation and how to improve them. Use the results to direct your prevention efforts into the places where they might be most meaningful. Look at what you're making inroads on. What are you doing well with? Maybe you're doing great with CLABSIs, but you're falling behind with CAUTIs. So you can put your prevention efforts where they need to go. You can discuss these validated results with hospital epidemiologists and the rest of your infection prevention team, with your infection control committee chair, and strategize for next steps. Where will you turn your attention next? You can show your validated results to partners, show them to your C-suite, and convince them that these are real. These are real cases, these are validated cases that your facility has prevented, that you've validated information that shows that you've saved your facility money. Show that you can explain methods to the Joint Commission if they should ask about how your surveillance and validation system runs, and that your facility will be able to stand up well to a CMS audit if you should be on the list to be tagged next. So that's all I have to say, but I'm happy to take questions and comments. Thanks very much. Hi, go ahead.
You alluded to the
Sorry.
Is that better? You referenced the data validation that CMS was doing for CLABSI.
Yes.
Having done CAUTI and SSIs for a year now, have you heard what CMS is going to do for validation for the CAUTIs and SSI, or if they will be?
No, I think we will all be notified about that at the same time. So we are working with them to help them do things in a way that is in accordance with NHSN methods and definitions. But you know, they have their own time frame in which they discuss that information. So, hello?
In validating surgical wound class, sometimes I'll come across a case, for instance, a colon that started out as a perforated viscous, so I know it should be a contaminated class 4, and yet it's documented as a clean contaminated. So at that point, I notify the director of the OR, and sometimes it gets changed, sometimes it doesn't. What should I be reporting into NHSN for wound class? The one that I know is correct, contaminated?
That's a good
or
point.
the one that's documented?
I'm going to ask Teresa to come up here and help me with that question. So when you say sometimes it's changed, sometimes it's not, where do you mean it's changed?
In the electronic medical, in the OR record.
In the OR record, but not in NHSN. And you've got an electronically uploaded OR information.
An electronic OR record now.
Mm-hmm.
But you know, sometimes you go through and you know that this is not a clean contaminated because it's perforated.
Right, and so I would say that it needs to be changed in NHSN, regardless of whether it's changed in the OR record. Is that
Yeah.
To enter it as it should be in
As
NHS.
I think it should be.
Yeah.
Thank you.
No, it won't match if the data are valid. If somebody comes behind in validation and says, "Oh, you know, they don't match," that's one that will be adjudicated, and I'm sure that we would also agree that it should be a 4, and so in this case, you would be correct, and the record would be wrong.
Dr. Arnold, excellent talk with some very, very practical, I guess, examples of how you can validate data. The one thing I would say is that when you mention involving the LIS team and getting custom reports, that's much easier said than done. I would just point out that every single time that someone asked for a micro query, for example, it goes into some kind of a queue for priority. And so what I would suggest, based on what I've been hearing from IPs across the country that are dealing with paper reports that don't even have any kind of sorting mechanism other than having the patient names alphabetized, is that we take those documents in and show them to administrators and say, this is what we're doing with our time. You're wondering why we're not doing well on hand hygiene. You wonder why we don't have evidence-based practices going on at the bedside. This is why we don't have IPs out in the field seeing what's going on, because they're tied to a computer or a piece of paper that they're going through and highlighting what they need to look at, and then transcribing it into an Excel spreadsheet. So, you know, when you think about all of that time that's being taken, that doesn't even have anything to do with analysis and going to the chart. This is just the process of going through trying to get the data to even look at it. So I know that process of talking to the lab and asking for a custom report. You're absolutely right. It should be a no-brainer, but it isn't.
Thank you for that comment. I want to just respond in two ways. I understand that a lot of what I discussed is not necessarily possible at all hospitals now. Probably much of it is not possible at all hospitals now. But for hospitals that can do these things, it's wonderful to start doing them. And for hospitals that can't do them yet, help your hospital grow in a direction where it becomes possible. And I agree with you that, you know, IPs need to be their own advocates to the powers that make their work possible. And there are coalitions building to try to help with that too. And I don't think there's any one agency that has a role of, you know, saying IPs need this or that. But in states where they have been able to do external validation, this is part of what external validation involves, is evaluating the work that has been accomplished by the infection prevention team, and where there are deficiencies or where people are struggling mightily to sustain a minimal outcome, that those the advice and the need for support for the IP needs to be directed to the facility level, not just to the IP. So thanks for that.
I have just a quick comment. The what you described is a continuous improvement aspect of our data.
Okay.
So how do you answer an IP that's entering data right now, knowing they haven't gone through this process and their needs? I mean, I think we've been the novice just trying to get it done, and now we should be growing and validating. I have an IP within our system who said, I'm not entering influenza data because I know I can't enter it correctly. And I'm responsible for that, and that's a Medicare fraud, and she's accurate. So how would you respond to that while we're in this place where we're trying to build these processes and have valid data?
Are you talking about the current rule for healthcare worker influenza
any
information?
Of these protocols. That just happened to be the conversation we had around that one. But really, any of these, I think anyone in this room knows we have weaknesses. And yet we are submitting that data. And I think we're all on board to continue to prove. But I'm just curious what the answer is in this place we're at now. And how do we build that confidence at this point today?
You know, I think each of us here needs to go back to our facilities as a messenger, an ambassador, a trainer, and, you know, bring your team together. Bring your APIC chapter together. Make sure that everybody is as good at this as possible. Make sure your data collectors are as good as possible, that your data entry folks, your data managers are doing this to the best possible. The IP is the team lead on this. So the job of coordinating is yours, but it requires a lot of work. So. Yes, hello. Oh, do we need another?
Yeah, I'm sorry.
Okay.
Yeah, we're out of time.
I'm so sorry. I guess we're out of time, but I can meet you at the back if you'd like.